So we're talking today about foot and ankle injuries, and in an hour or about an hour, it's impossible to go into huge amounts of detail on any one thing or another. So what I've tried to do is to cover a broad selection of things that occur in the foot and the ankle. That's why I've classed it from minor to major. I'm an orthopaedic trauma surgeon based in Birmingham. I've worked in DGHs as a consultant and now in a major trauma centre. And even in a major trauma centre, we still get what we would class as relatively minor things coming through. Ankle fractures and foot and ankle injuries occur both because of big trauma that can be high and low energy, and because of general frailty. We get an increasing number of older patients coming through with quite severe foot and ankle injuries from completely minor stumbles and trips, just leaving their foot effectively caught on the carpet while the rest of their body spins around on top of it. Whilst most foot and ankle injuries could be classed as trivial, causing a minor inconvenience and stopping you from playing football for a few weeks, Anna, or even doing anything, going to work for a short period of time, they can, of course, be quite major and result in life-changing outcomes with arthritis, stiffness, even amputation of limbs. And as I said, it's impossible to cover everything in a huge amount of detail. So we're going to give a broad overview. And then, of course, if you've got questions about other things that I haven't covered, I can try and answer some of those towards the end. We're going to talk about the principles of assessment, some of the diagnoses that we can see, and a bit about the management of specific cases as well. So, I found a couple of papers when I was writing this, and one of them was basically saying that in 2016 to 2017, there were over 20,000 hospital admissions in this country, the United Kingdom, where ankle fracture was listed as a diagnosis. That gives an overall incidence of 44 per 100,000. Now, that costs over £68 million in healthcare costs. And then if you look at primary care records, we can see that actually the incidence of all ankle injuries, because of course this primary care covers non-hospital admissions as well, there's an incidence of about 75 per 100,000 in the under 50s age group and the 104 per 100,000 in the over 50s age group. Now, I'm now just over 50, so that's obviously causing me a bit of a worry. But the older that you get, the more likely you are to injure yourself in general. And when you're younger, you're more likely to be involved in the more traumatic causes of injury, such as sport and road traffic accidents and general outdoor activities. So when we talk about looking to assess these things, the first thing you've got to take into account, because I'm very conscious that there's a broad range of people that I'm talking to, be safe. You're no good to anyone if you put yourself in danger when trying to assess a patient. So make sure that it's safe to approach the patient and that you're working in a safe environment. Always work inside your capabilities. I have a different skill set to a paramedic, or I have a different skill set to a pitchside first aider. And the pitchside first aider would possibly be a much better person to be looking after somebody on a rugby pitch than me. But I'd also suggest that there's things that I can do in the field that other people couldn't. I'm happy to do certain things. Other people will not be. I am supported by my training and my indemnity. And if you're not in a safe governance structure that allows you to do things, then please don't, as Anna suggested in the introduction. Don't allow yourself to be distracted by injuries that look dramatic. A good example of this, going back to rugby, I'm not a rugby player, but my son plays rugby, is a player who gets their ankle broken at the bottom of a ruck when the players collapse on them, but then he's quietly bleeding away from a ruptured spleen that occurred from the person who fell on top of him. So it's very easy to be distracted by something that looks nasty and that is highly visible. So just make sure that we always start with the mantra that we were taught at our parents' knees, which is CABC. So just make sure that the patient is safe and secure before you do anything. The basic structure of working out what's going on with someone is always the same. It's history, examination, tests, and then plan. And those things interact with each other. While we're taking a history, we're looking at the patient. We're seeing what's going on. We're coming up with a bit of a plan even before we've got the test, because we start having suspicions about what's going on. And the other thing I'd ask is that you start thinking about rehabilitation from the first contact. It is absolutely vital that every person who looks after an injured patient, it tries to build some sort of rapport with them, because the patient will remember, in the most part, every step of their journey. They will want to be able to say, oh, the person who looked after me on the pitch was really kind. The paramedics who took me to the hospital looked after me. They made me feel safe. The nurses and the doctors in the emergency department were kind and they listened to my concerns. And all of those things build up to a successful journey. Because if the patient has issues in the run up to being rehabilitated, their rehabilitation will suffer, because they'll either have a higher chance of psychological issues or lack of engagement in the healthcare system. Obviously, you can't make it easy for everybody all the time, and there are always going to be struggling people out there. But we all have a duty to try and deliver the best care that we possibly can. So, in the history, these are the things I want to know. When did it happen? I want to know if it's fresh or if it's delayed presentation. I want to know when the joint was dislocated, for example. I want to know what happened and how did it happen. Was it a crushing injury, a twisting? Was it an axial load where if somebody fell from a height? Was it a direct blow? Where did it happen? Did it happen in this country? Did it happen overseas? Did it happen in a barnyard? Is it covered in horse manure? That type of, those sorts of introductory questions are very important. Why did it happen? Was it a road traffic collision? Was it sport? Did they collapse? Was alcohol and drugs involved? Are there any relevant comorbidities? For example, diabetics are well known to develop neuropathy as their disease progresses. And if they've got a loss of sensation in their lower limbs, they're more likely to have problems. And what happened after the injury? Were they able to carry on walking? Were they able to carry on playing sport? Or did they have to stop? Now, a lot of people can still walk on their ankle injuries if they're given suitable encouragement. But even walking with a limp is a very important piece of information. And I'll come on to why shortly. We need to know if they're smokers, because smokers have worse wound healing, worse bone healing, and tend to have more post-operative problems. And like I said, we need to know if they're diabetic, and there's other disease processes that we want to know about as well. So after we've taken history, we want to have a look at things. But as I said, these things overlap. We're doing them at the same time. So we want to look, is the injury open or closed? Has the skin been breached? If the skin's been breached, then you have to assume until you know otherwise that goes to the bone. If it goes to the bone, then we have a relatively small period of time to deal with that wound, to get it clean, to reduce the risk of infection later on. We want to look for bruising, swelling, see what colour the limb is, see if there's any evidence of deformity. All of these things will contribute to the decision-making about the destination that patient will be going, or the destination they need to be taken to. So whether they are able to be taken to a trauma unit or whether they need to be taken to a major trauma centre, for example. I would suggest that anyone with an open lower limb fracture should be looking at going to a major trauma centre, or at least a unit that delivers the plastic surgery and orthopaedic surgery reconstruction, because the best outcomes occur when they are delivered there straight away, so that the first surgery that the patient gets is being done by the surgeons who are likely to be involved in the reconstruction. Having to do secondary transfers of these patients is a real pain for both the hospital that wants the patient to come to their service, the hospital that wants to move the patient out of their service, and to the ambulance service, who have to provide an ambulance that could be better used getting patients from the field. Bruising and swelling is often associated with specific injury patterns. I've got an example of that to show you later. And in general terms, the more swollen and more bruised the ankle and the foot is, the likelihood of there being a more significant injury goes up. It is possible to break things without very much swelling, but it's impossible to have a significant injury without signs, except if you're neuropathic and diabetic, for example. We need to see if there's any evidence of deformity. So a severely bent tibia or a dislocated ankle can interfere with the blood supply distally. And as long as you're happy to, realigning that limb or reducing that dislocation is in that patient's interest. Leaving an ankle dislocated for a long period of time puts pressure on the soft tissues around it and increases the chance of the bone of the skin breaking down and the bone protruding and it becoming an open fracture. If that happens, the patient's more than likely going to need a flap from the plastic surgeons to cover it, which massively increases the risk to that limb and that patient. They're also really painful. Any of you who have had a dislocation will know how uncomfortable that is. And usually the relief that you feel when it's put back in is pretty impressive. But as I said before, you do have to have a certain skill set to be able to do that. There's nothing wrong with trying to straighten a bent limb out. And I don't think anyone would ever criticize anyone for that. But you do have to do it within the confines of a governance structure. Like I said, as a trauma surgeon, I'll be happy doing it myself. And I'd quite happily take over from someone to attempt to reduce it. Okay, so I've got some pictures because you want an orthopaedic surgeon to show you pictures of gory things. So this first one that I'm pointing to now is a fairly typical elderly patient that we see probably once a fortnight, once a month, which is an elderly patient who's stumbled. They have hardly done anything at all, and their foot has stayed in one place while their body has moved over the top of it. And that's caused the tibia to come out through the medial side of the skin. There's not much in the way of any skin loss. It's a rip, basically. And very often, if we get to these quickly enough, we can deal with these with one-stage surgery, debride it, close it, and get the wound closed over the top without having to do free tissue transfers. If this was an 18-year-old who'd come off a motorbike, there would be a massive hole there, which would need a free flap to be moved. In the center here, hopefully you can all work out what that is. That's a dislocation. You don't want to ever see that. If that's left out for much longer, then this skin here is going to die. It's under a huge amount of pressure from the tibia on it. We can't see what's happening on the other side of the ankle, but that is likely going to break down and come out if it's left for very much longer. This patient here has got bruising that classically tracks down to this watershed line here. And this is usually seen after a few hours after an ankle injury. It's very unusual to get it straight away, unless you've had a tendon rupture, where you often get some bleeding around it. This amount of swelling here doesn't really give you much of a clue of what's going on. But if this ankle was 3 or 4 times the size of this and massively swollen, that would give you raise some alarm bells that there's something more significant going on. And this final one here is a picture of the sole of a foot with plantar bruising. Now, this plantar bruising is a key sign of an injury to the midfoot. And if you see that on a patient, and that occurs quite quickly, then you have to rule out, rather than assume that there isn't, but you have to rule out a significant midfoot injury with both plain x-rays and advanced scanning if necessary. So what are your immediate actions going to be? You're going to record it. A picture tells 1,000 words, and it is always useful to see photographs of wounds and injuries to see how it happened, where it happened, and what it looked like. It also means that after you've covered it, having removed any big bits of debris that might be stuck in the wound, you don't have to keep taking the dressings down, because every time that somebody takes the dressing down, there's a higher chance of infection getting in. I refer to the BOA, the British Orthopaedic Association, the BAPRAS, British Association of Plastic and Reconstructive Aesthetic Surgeons, guidelines that were published a number of years ago now and been updated in the about 5 or 10 years ago, which are the guidelines on the management of severe lower limb open fractures. And if you've never read them, it's worth getting. You can just Google them. If you put BOA BAPRAS guidelines, it comes up, I think, as the first or second hit. The guidance there tells you how to manage these injuries, and it emphasizes that you don't wash open fractures until you go to an operating theatre, because all you do if you pour water on an open fracture is push bits of rubbish deeper into the wounds. We remove any big bits of twig that you can obviously see, and then we dress the wound with the saline-soaked gauze. If you can, reduce it. If you can take the pressure off the soft tissues by realigning the limb, reducing a dislocation, or straightening out something that's wonky, then you may well save some of the surgical insults that need to be done. You'll probably make the patient more comfortable in the medium term. They might not like it while you do it, but afterwards they should feel a lot more comfortable. And it will hopefully reduce some of the further insult on that limb. And then, as I said, usually you splint it, okay? Not everything has to be wrapped up in something big and supportive, but a box splint or some sort of other splints to hold it still whilst it is further assessed is always going to be a good idea, and you'd never be criticised for doing it. So having immediately managed things by looking at it, taking the history and doing the immediate splintage, we need to have a feel of it. The important thing with this is make sure that you've actually had consent from the patient before you lay a hand on them, because otherwise it's an assault. And my strong advice is to always have a chaperone present when you're doing it, even if you're not doing something that you would class as particularly intimate. There are some slightly strange patients out there. One of my registrars has got a complaint ongoing at the moment from a patient who's basically accused them of assault. But very luckily, he had a chaperone with him. So there's a witness to say that actually none of what has been alleged has occurred. Be gentle. They're going to be in pain. They're not going to be particularly happy about having fingers stuck in things. My wife regularly tells me I've got very painful fingers, and she feels sorry for my patients when I examine them. But I reassure her that I do try and do things as gently as possible. Try and be systematic and develop a routine for when you're examining things. It doesn't matter whether you start at the front or the back of the ankle, the medial or the lateral side, as long as you do a thorough examination, if it's indicated, making sure you follow your routine so that you know that you've assessed all the areas. Assess the neurovascular status. One of the questions I saw that came up in the box just before I started talking was about feeling the pedal pulses. They can be very difficult to feel. So not feeling a pulse is not the end of the world. But what you have to assess is the general circulatory status of that limb by looking at their capillary refill, the color of the skin, the temperature of the skin. Does it feel like it's perfused? And most people have a second side. So compare it to the other side, especially if it's uninjured, so you can see if it looks significantly different. And having felt it, we want to try and move it. So ankles go up and down. The subtalar and talonavicular joints, which contribute the joints effectively in the hind foot, the subtalar joint where I'm pointing at the moment, and the talonavicular joint, which is between the talus and the navicular bone and the junction between the hind foot and the midfoot, allow the heel and the foot to swing from side to side. Your midfoot gives you some movement up and down, and the forefoot moves up and down at the MTP joints where the toes join the body of the foot. Now, in combination with the examination, the movement, come the Ottawa ankle rules. And pretty much anyone who works in the emergency departments will be aware of these. It was an incredibly useful piece of research that was done on the basis of examining x-rays and histories that were taken from patients in emergency departments in Ottawa by the emergency department doctors over there. And the idea of these rules was to try and reduce the ordering of x-rays for two reasons. First of all, it increased the speed of throughput through their emergency department, so they didn't waste 45 minutes to an hour with having patients being x-rayed when they didn't need them. But it also reduces the radiation dosage that patients are exposed to. What they realized is that the majority of the ankle injuries that come to the emergency department and go to primary care physicians are actually soft tissue injuries. And they obviously don't need x-rays. It means that you can more easily justify getting x-rays of ankles performed and feet performed. And it tries to stop doing unnecessary radiographs. So to be able to implement these rules or use these rules, it's on patients over the age of 2 years with a history of trauma who have normal or pre-injury normal sensation in their feet. So they're not particularly helpful in diabetics. Now, these rules are very good at ruling out injuries. So they have a high sensitivity, but they have a reasonably high number of false positives, which means they're not particularly specific. So they can contribute to the care of patients, but they don't overrule clinical suspicion and fear of injuries. So what do they actually say? The important final thing from this that I'm going to come on to before we start talking about where you examine is it comes out that you rarely need to get an x-ray of the foot and ankle. You should be able to identify that it's either an ankle problem or a foot problem. And this goes down to having your ordered, reproducible system of examining things. So what we have to look for is pain around the malleoli, in the malleolar zones, so both medial and lateral side. And we're looking for pain in the 6 centimeters of the posterior ridge of the tibia, or medial side, and 6 centimeters on the posterior ridge or edge of the fibula, or at the tip, or an inability to weight bear immediately afterwards, or in the emergency department, walking 4 steps. So it's 4 steps, even if they're walking with a limp. If they meet those criteria, so history of trauma, pain in the malleolar zone, in that 6 centimeters around the medial or lateral malleoli, then an ankle x-ray is indicated. For the foot, it's very similar. It's mid-foot pain, plus pain at the base of the little toe, or pain over the navicular, and an inability to weight bear, as we mentioned before. Ideally, I'll talk about the type of x-rays that we'll get later, but ideally you would get weight-bearing x-rays if you can, but I'm a foot and ankle surgeon, so I always ask for weight-bearing foot x-rays. In the emergency departments and primary care, they're nearly always non-weight-bearing x-rays. What you've got to remember is still most injuries are soft tissues. And being able to walk or play on suggests that it's going to be more likely to be a soft tissue injury rather than a significant bony injury. If you do make a diagnosis of a soft tissue injury and that patient doesn't go to a hospital, always protect yourself by telling them what they should do if they're not going to get better, if they're not getting any better. Now, the majority of soft tissue injuries should be improving over the course of 7 to 10 days. They will get worse before they get better, but over 7 to 10 days, the general trend should be improvement. And if they're not getting better over that period of time, the patient should have an idea of what they do if there's a problem. One of the specific soft tissue injuries that you have to be very aware of and be very suspicious of is the Achilles tendon. The classic history is someone who is doing some sort of activity, and they said, I got hit, I turned around to give them a mouthful of abuse, but there was no one there. We see it regularly in explosive sports like netball, badminton, squash. We see it in people running for the bus. We see it with people just walking down the street. But the important thing is they all give a history of something going in the back of their ankle. And the people who attend late were usually seen by someone who told them it was just a sprain. But the history is pretty classic. They all say something just went at the back of the ankle. Just remember that even sprains, and there's no bony injury, really hurt. They can be very significant injuries. And there's quite a lot of people out there who have very significant soft tissue injuries to the ligaments around their ankles, who are in more pain and have more problems than people who have bony injuries. So the tests. I mentioned plain x-rays. We always get two views for the ankle, a lateral and a mortise view, and 2 or 3 views of the foot. Now, as I said, I always ask for weight-bearing x-rays because you want to have the foot loaded in a functional position to see what's going on. But if patients are in too much pain, then they can't have a weight-bearing x-ray, so they become non-weight-bearing. You always ask for an AP, an antero-posterior view, a true lateral, and an oblique, a resting oblique x-ray of the foot. Now, the traditional x-rays that get given in the emergency department, which most of the time are perfectly satisfactory, will be a non-weight-bearing AP x-ray and a resting oblique x-ray. And you can see most things on that, but there are a few things where the weight-bearing AP and the true lateral are particularly useful. We can get ultrasound scans. Now, what I always was told when I was a junior is that if you can put your finger on a problem, an ultrasound scan can help you because it's still a focused scan. They're brilliant for looking for tendon injuries, particularly the Achilles tendon. They're very helpful in some soft tissue injuries, but they're not particularly useful if you're looking for a bony type injury. If the pain is very generalized and the patient says, well, it's the whole of my ankle that hurts, an ultrasound scan is unlikely to be helpful. We can do CT scans. CT scans are excellent for looking at bone and joint alignment and to allow planning of surgery. Any dislocation should get a CT scan after the bone's been reduced. Any significantly displaced fracture would nearly always benefit from a CT scan to allow surgical planning. Fractures of bones like the talus and the calcaneum and the other tarsal bones need to have CT scans to allow you to actually make a decision about the management of those patients and whether they need to have surgery. MRI scanning is very useful, but it can be and looking for occult fractures. So there are things like stress fractures of the calcaneum, often you can't see on a plain X-ray. And because the bone's not particularly separated, they're not picked up on CT scans, but they're very easy to see on MRI scans. They can also help look for evidence of cartilage damage, because if you dislocate your ankle, you very often will tonk off a lump of the articular cartilage as well. And you may want to be looking for that fragment if it's inside the ankle joint, because it can cause problems with joint mobility afterwards. So we mentioned the Achilles tendon, and you want to be very suspicious for these. They, as I said, give a very characteristic history, and the best outcomes of management come with very early management. So the earlier you diagnose it, the better it will be for the patient. Because nowadays, the overwhelming majority of mid-substance tears are treated non-operatively. When I was a registrar, if you came into the hospital with an Achilles tendon rupture, you would almost definitely be offered surgery, you'd almost definitely get it, and you'd almost definitely have an operation that went pretty well, and patients were rehabbed reasonably well. But what we know now is that even in elite sports people, they can be managed non-operatively. Because what we've realized, and there was a team down in Bristol who did a huge amount of work on this, including with very high performance rugby players, that managing these patients with functional rehab in boots with wedges or splints that allow protected movement with early weight bearing and focused rehabilitation allows people to get back to full activity in just the same way as surgical treatment. Overall, it's the quality of the rehabilitation that matters and the level of engagement with that physiotherapist. So if the patient follows instructions, builds up their level of activities in a sensible and progressive manner, and doesn't try and do too much too quickly, then they should be able to rehab fully. I've certainly had patients with no Achilles tendon, because we've excised it because of infection, who've managed to rehab in such a way that you could not tell that they'd had no Achilles tendon. So it is possible with the right type of patient and the right type of rehab. If you avulse your Achilles tendon from the heel, then they nearly always need surgery, unless you're prepared to live with without an Achilles tendon, which you might well be if you're in the elderly group, or in diabetics with peripheral neuropathy. And you can see on the plain X-ray that on that slide the appearance of a bony avulsion. Now, you'd usually look at the back of the ankle and see a huge amount of bruising and contused tissue. It can be difficult to justify doing the X-ray, but they will say it hurts here, and they'll put their finger on where the avulsion is. And it'll be different to an Achilles tendon rupture, which is usually in the middle and the mid-substance. So moving on to the bony bits. On the this is an AP and lateral view of an ankle. So you can see we've got the tibia, the main bone, the medial malleolus on the medial side, the inner side of the ankle, the talus sitting underneath the tibia, with the fibula on the outside. Now the fibula is joined to the tibia by distal tibiofibular ligaments, one at the front and one at the back, called the anterior and posterior ligaments, funnily enough. There's a strong and thick sheet of tissue, the interosseous membrane between the fibula and the tibia. But this area here in the syndesmosis is a joint. It's lined with articular cartilage. The lateral malleolus is secured to the talus with a bunch of ligaments, one at the anterior part, one that goes down to the calcaneum in the middle section, and a posterior ligament at the back. So you can see how the talus is contained within this squared off horseshoe, effectively, by bones and ligaments that form an articular cartilage lined joint. On the lateral view, you can see the calcaneum, the big heel bone sitting at the base, the talus underneath the tibia. And you can see that the fibula is located slightly posteriorly to the tibia. It's not perfectly in line with it. So the principles of managing ankle injuries are the same, whatever severity of injury that you've got. We're aiming to have a congruent, stable ankle that is stable and allows the foot to be plantigrade and planted firmly on the ground. So congruence and stability are the key things that we're looking for. The stability of the ankle is given by the medial and lateral ligaments, but also by the syndesmotic ligaments that hold the fibula to the tibia. The bony shape of the ankle contains the talus, as we talked about, and having a smooth, congruent joint is essential to minimize the risk of developing post-traumatic arthritis. And the congruity comes from the smoothness of the joint surface and the correct positioning of the fibula. So it doesn't matter if the joint is lovely and shiny and smooth, if the fibula is not sitting where it's supposed to be, because that will allow the talus to effectively rattle around in the ankle joint. So we need to be able to assess the ankle joint stability, both at the tibiotalar joint, so the ankle joint effectively, and the tibiofibular joint as well. So why do we operate on people? Okay, this is now another elderly patient. We've managed to move her displaced bimalleolar ankle fracture dislocation on the left of the screen as you look at it, and we've reduced it in a closed manner to the position in plaster. So why would we want to operate on somebody like that when we've got an X-ray that looks perfect? The bottom line is you don't have to operate on somebody who's got an X-ray that looks like that. There's been a trial in the reasonably recent past which showed that full contact casting, in other words, putting a fairly tight fitting plaster on a ankle, particularly in low demand older patients, can give very excellent outcomes in the form of a stable, congruent, and comfortable joint. However, when you've had a dislocation like this, the ankle is very unstable and wobbly, which means that it's highly likely to lose its position. And what we're looking at is to try and maintain the reduction as best we can. So whilst we can treat things in a plaster, we often will not and go for surgical reconstruction, even when the X-ray and the plaster looks acceptable, to minimize the chances of that joint effectively falling apart. So when we classify these ankle fractures, one of the most popular classification system is the Dennis-Weber classification system, or the Weber classification system, which basically looks at the lateral malleolus and the type of fracture associated with the lateral malleolus and its relationship with the syndesmosis. There's three types, A, B, and C. Type A, as you can see on the left-hand side of the screen, is below the level of the syndesmosis. That is quite a distal and one that you can see there. That is effectively like a bad sprain. So instead of the ligament rupturing, it has pulled the bony footprints of its attachment off. Those types of fractures really don't need any treatment at all. They can be managed in a boot, they can be managed free or with an ankle brace, but they do benefit from physiotherapy. They're often really sore still, so they will need crutches. But just because the bony avulsion is very small doesn't mean they need anything doing. They don't need to necessarily be seen by an orthopaedic surgeon in the fracture clinic, as long as they're followed up in a rehabilitation service, either sports medicine or a competent physiotherapy group. The type B fractures are at the level of the syndesmosis. Now, these often are stable, but they're not always. So we have to look at other ways of working out whether these are stable or not. The type C fractures are above the level of the syndesmosis. And that's in combination with what we're talking about with the B, is where your examination becomes very important. Because if there is the presence of medial pain, that raises the suspicion of injury to the deltoid ligaments, even if there is no obvious fracture. And if the deltoid or medial ligament is injured, that can affect the stability of the talus, because it'll have lost the guy rope that holds it snug on the medial side, meaning that it can drift off. So this is an X-ray of a stable Weber B fracture. This is patients coming to my fracture clinic on Friday, as it happens. And you can see the fracture at the level of the syndesmosis here on the AP view, and you can see it here on the lateral view. We can see that the talus remains nice and snug in the ankle joint on the medial side. She doesn't have any medial pain because I read her notes. I haven't physically examined her myself, but you can see that it's perfectly reduced because the gap here is the same all the way across. So we know that the talus is sitting nicely in the ankle joint. On the lateral view, we can see that the foot is at 90 degrees or plantigrade to the axis of the tibia. So we know that the talus is sitting in the correct position. And we can see on the lateral side that whilst the fibula doesn't look completely flush with each cortex, it's because of a rotational deformity here. On the joint surface sides, it's nice and smooth. So this is a stable fracture that can be managed in some sort of walking splint. We don't want to put these in a plaster if we can avoid it, because it makes the ankle stiff. It increases their risk of deep vein thrombosis, and being in a plaster for 6 weeks is horrible if you don't need to be. So we try and get these either into an ankle brace or a walker boot so that they can weight bear as tolerated and get moving on them and start their rehab nice and quickly, getting their ankle movement as soon as they're able to. To assess whether the Weber B type fracture is unstable or not, we can do this particular X-ray, which is called a gravity external rotation view. And it is a very simple one to do. It doesn't particularly hurt the patient. They basically lie on a X-ray table on their side with the fibula or lateral side downwards, the medial side upwards, and gravity will cause the talus to shift if the fibula is unstable. And we can see that it's shifted because this medial clear space has increased. Now, sometimes you can see this without getting a gravity external rotation view if the ankle's actually slightly subluxed. But in that patient that we just saw, they had this X-ray done as well, and it looks completely normal. On this here, we can see that the medial clear space has increased, which means the talus must have moved with the fibula. Now, that's going to increase our desire to treat this with an operation, because an operation here is very straightforward. It should be carry a very good outcome, and it can stop that ankle from causing problems. Because if that ankle is left unconstrained in the joint and the talus is wobbling around, it will become arthritic quite quickly. So I mentioned the syndesmotic ligaments. These drawings here are trying to show you what they look like. And we can see the fibula here with the tibia here. And we have the anterior, inferior tibiofibular ligaments. So it's at the front. It's the AITFL. And at the back, predictably, we have a posterior, inferior tibiofibular ligament sitting at the back. So those two ligaments basically secure the fibula to the tibia, and it's supported by this interosseous ligament that runs all the way up and down here on interosseous membrane. If you have a high fibular fracture, so a Weber C type fracture, it can propagate the force down through the membrane here, through one of the or both of these ligaments, through your ankle joints, and out through the medial side, either through the medial malleolus or the medial ligament, causing the ankle and syndesmosis to be unstable and displaced. And we can see that in this type of fracture here. So we have a higher fracture here. You can see there's increased medial clear space on this X-ray view here. And we can also see that the tibiofibular joint is not lined up. So this could be treated without an operation. But if they're treated without an operation, that patient will get post-traumatic arthritis, probably very quickly. They will not rehabilitate. They will not be able to return to the activities that they want to be able to return to. So to try and maximize their chances of recovering, we want to reconstruct the ankle to make it look like an ankle again, to restore the length of the fibula, the rotation of the fibula, and the relationship between the fibula and the tibia. And we've done this with a plate and screws here. And these two screws go across the tibiofibular joint. They're called syndesmosis screws because they're screws that go across the syndesmosis. And they're there to secure the tibia in the right place whilst the ligaments recover and heal. In the old days, again, when I was a trainee, we used to take all these screws out. And then there's been lots of bits of research that said that taking them out or leaving them behind makes no difference to function. So nowadays, we don't take them out at all. We just leave them to break unless the patient has particular problems, in which case we'll take them out on a case-by-case basis. So the other thing that is important in assessing the stability of the ankle, apart from the presence of the injuries to the syndesmosis, medial side, is the backside of the ankle joint, the posterior malleolus. So if you have a posterior malleolar fracture, that will effectively fracture the bone that has the insertion of the posterior inferior tibiofibular ligament. So the bigger the chunk of the bone here, the more of the ligaments footprints attached to it. But also, if you take off in this case, nearly half of the joint surface, that's going to lose one of the constraining parts of the ankle joint, allowing the ankle to slip out the back. And you can see on this X-ray here that the talus is posteriorly placed in the ankle joint. It should be sitting around the front here, but it's already slipped out the back. So again, whilst you could treat this without an operation, you'll end up with a rubbish ankle at the end of it. So we want to try and improve this ankle by doing an operation to bring the bone into the right place. And the only way that you can do that is by making cuts in the skin and using plates and screws or another fixation device to hold it in the right place. We use screws, plates, nails, or intermedullary rods, and this is a fibular nail. And this is in the lady whose X-ray I showed you earlier in the presentation. So in this case, we've put the rod up to stabilize the lateral malleolus. She had some peripheral neuropathy. We didn't want to make big cuts in the skin, and you can insert this through holes that are about 2.5 centimeters long. And it has given her a strong ankle, and she's able to walk on this. You can also use sutures, of course, in ligaments and tendons. They don't tend to work too well in bones. So the posterior malleolar fracture that we saw a moment ago has been fixed here with a plate round the back. This plate here is to support the medial side, because what you couldn't see on that scan, because I didn't show all the slices, is that there is also a medial side split that needed to be pushed into the right place. And we've used this plate on the fibula to hold the fibula with the right alignment and out to length. Now, different to the X-ray I showed you earlier that had the syndesmosis screws, there are no syndesmosis screws here, are there? And that's because we fixed the posterior malleolus, and the posterior malleolus had the ligament attached to it. And if you reconstruct the posterior malleolus with the ligaments attached to it, you shouldn't have to put syndesmosis screws in as well. So that was internal fixation. And we've talked that we can use plaster. We've talked that you can use plates and screws and implants. You can also use external fixation. So external fixation, as you can see from this CT reconstruction, are pins, bars, and clamps that are applied to the outside of a leg or a limb to hold it in the right sort of alignment. So there's two types of external fixation principles: damage control, where we want to use a modular pin-bar combination that allows us to put pins and bars wherever we want. And there's definitive care fixators, which are more like circular frames, which you might well have seen either on the television or in your hospitals. I don't put circular frames on people. I've done a few in my time, but they're far too complex for my brain. I'm lucky I work with three colleagues who are very good at putting, four colleagues who are very good at putting those frames on. And it is a specialism in its own right. This patient is one that I did. He was a motorcyclist who was hit an oncoming car. Hopefully you can see that there's a complex fracture of the distal tibia. It's not really an ankle fracture. That's more of what we call a pilon type fracture, but it goes into the ankle joint. It was open. There was a hole that was about 3 centimeters on the medial side, which we've extended to clean out the bone. And we've also removed probably a 6.5 centimeter length of bone. That you can see the plate of bone here. There was where's my arrow gone? Can't find the cursor. Sorry, there we go. So there's a plate of bone here. There's a corresponding one at the back of the tibia that came out because I had no soft tissue attachments. And you can see that after the debridement and the stabilization, we've got a block of bone distally at the ankle. We've got the proximal bone here. It's all nice and stable. And we can then allow this temporary fixator to allow the soft tissues to recover and settle down before we do our definitive reconstruction. We're aiming to allow the physiology to recover from the first hit of the accident and the second surgical hit, where we take them to theatre, we make them cold, we fanny around for a period of time, causing more inflammation and more inflammatory factors to be floating around the body. And that's the second surgical hit that we want to minimize. It can give us stability whilst we're waiting for the appropriate skill set of surgeons to appear. I said, I don't do circular frames. And that patient there was an ideal candidate for a circular frame, because you can't put plates and screws in that because the defect is too big. You'll end up with a big bone gap. Any plates and screws will fail. You've got to grow new bone first. And it also allows options to be discussed with the patient. We always try and save limbs. We try and put things back together again. We try and keep you with the number of toes, feet, ankles, legs, arms, hands that you were born with. But it can sometimes be the most important decision and the first step to rehabilitating that patient to actually recommend an amputation for them. An amputation for severe lower limb injuries is a very valid treatment option, and sometimes is by far and away the most sensible option for that patient to have. Because we like to have patients involved in their decision making, we almost never do a day one first debridement or first operation amputation on a patient if we think it's not life-saving. Occasionally you have to do that because it's a life-saving procedure, but almost always we will do a staged procedure where we debride it, externally fixate the leg, and then have a discussion with the patient afterwards, because that way we can involve them in their decision making. And as we said, the important thing here is to take people along with them for the journey, so that they understand the processes that are going on, so that they engage in their rehabilitation. And they've already been through enough with the accidents. They don't want to suddenly wake up and realize they haven't got a leg there when they thought they were going to. So that was the X-ray we took in theatre. You've seen the CT reconstruction, but you can see it's all in bits. It doesn't look like an ankle. It's horrific. This is a CT reconstruction, which looks even worse. That was the best picture, unfortunately, I could get of it. But the picture next door to that is what the operation he actually had done about 2 weekends ago. So the problem with his injury is that the bone block at the ankle is too small to allow it to be stable for the reconstruction. So the only way to keep his leg is to put a bone transport circular frame on. And that frame that has been applied there has got fine wires and half pins in it. And the idea is it'll drag the tibia down to dock with the talus so that he can grow back. There's about 9 or 10 centimetre bone defect that he's got here. That fixator will be on him for 18 months or so. He'll grow to love it or hate it. And once it's taken off, then the tibia should have regrown down to the talus. It's pretty phenomenal. He was offered an amputation, because if he'd been given an amputation, he'd have probably been on a temporary prosthesis within 6 weeks. So the initial recovery onto a prosthesis is really fast. The physiotherapy and the rehabilitation techniques now for a well-performed transtibial amputation allow people to get mobile very, very fast. The problem is you have the permanent ongoing cost of prosthetics. And usually as patients get older, the amount of time they spend on their prosthetics goes down, and eventually they do become wheelchair bound. So if you can keep your limb, then you're able to function better usually, but it's a very long process. As I said, that frame will be on for probably 12 to 18 months. He will have infections. He will have problems. He might need further surgery to get the bone to heal. He might come back saying he's had enough and he just wants an amputation. And that happens reasonably regularly. Now, the other reason for putting a temporary X-fix on him is, rather than going for that frame, first of all, is that frame took best part of 6.5 hours to put on. This patient also had this injury. He has got a fracture dislocation of his right hip. So that's the head of his femur bone there. That should be stuffed in the acetabulum here. So he's broken the neck of his femur here and dislocated his hip. This bone here is pressing on his femoral artery, and affecting the blood supply to his lower limb. This is another reconstruction here where you can see it. So that needed an operation as well to put it back in. Luckily, he came in at a time when one of my colleagues who does all the pelvic, or a lot of the pelvic surgery in Birmingham, was still in the hospital. So he stayed on the Friday that he came in to do it for me. So I didn't have to, because I must admit, I've never had to fix anything like that before. And I was very glad that Julian stayed to do it. So damage control allows you to stabilize injuries either while something more important gets done, or allows you to temporize things so that you can come back later to spend a long period of time operating on someone when they're fully resuscitated. So moving on to other bits now. This is x-rays all from one patient. He was a rugby player who injured his knee, and he couldn't walk because his knee was hurting so much. So he came in and luckily was examined properly, both by the paramedics, because they actually pointed out that his ankle was swollen. They thought something funny was going on there too. And the emergency department staff who saw him also had the sense to x-ray the whole bone. And it's always a good idea to x-ray the joint above and joint below to make sure that you don't miss things. And what he's got here is a tibial plateau fracture here. And then if you look at the x-ray of his ankle here, which I've zoomed on the left-hand side here, you can see that there's an incongruity on the talus. You can go along the edge here, and then, it falls into a gap, and it goes up here. So he's actually split his talus. You can tell something's funny is going on. The joint is not congruent. It's not evenly spaced all the way across. Something strange has happened. And you can see on the CT slice here that there's a big step in the talar dome. Now, as I've said several times before, you don't have to have an operation for this. You could manage this non-operatively. But if you do that, you will have a rubbish ankle. So treating it non-operatively is a rubbish idea if you want to be getting back walking on this. And the problem with the talus is that injuries to the talus can affect the ankle and subtalar joints. So a very small bone has an effect on two joints, has a very delicate blood supply, and you have very difficult access to it. So this bone is almost completely covered in cartilage. It's got about 4 entry points or 5 entry points for arteries, which are very easily damaged either by a surgeon or by an injury. And what we've done to reconstruct this is take his medial malleolus off so that we could see the joint. And then I've used a couple of screws to reduce the, to reduce and hold the talar fragment in the right place. And then used a small plate that you can see just underneath here to stabilize the talar neck component. We then reconstructed where we divided the bone, the osteotomy with the plate and some screws. The calcaneum or heel bone nowadays is a lot of these fractures are treated non-operatively because there had been a study that was done across the country called the UK heel fracture study, which we'll talk about on the next slide, and that suggested that the overwhelming majority of patients would do just as well, both with or without surgery. These fractures usually result in crushing, so loss of height of the bone, and bursting of the bone, so the increased width. I'll show you a CT scan in a moment to try and illustrate that. You can see on this comparative photograph with a broken and a normal one, you can see how much wider, bigger and swollen and just generally painful looking that broken side is. You can't really see the loss of height there, but there is loss of height as well if you x-rayed it, and certainly compared to the normal side. So this UK heel fracture study was a study that was done nationally, had over 100 patients enrolled in it, and provided they met the entry requirement, they were randomized either to surgery or no surgery, and then they were followed up. And there's been 5-year follow-up papers that have suggested that there's no benefit in surgery on these patients with these fractures unless they have impingement on the fibula from the lateral wall. Now, impingement basically means irritation or rubbing. The lateral wall is the outer wall of the calcaneum. And this is a CT scan slice of someone who's had a calcaneal fracture. You can see the sort of fracture line running up about here. And you can see that this lateral side here is pushed out and narrowing the gap on the fibula here. So if you have patients with acute fractures that have a lateral wall that is pushed out in that way, we'll often look to do operations on them. So we still do surgery to enable easier salvage later on. And the salvage surgery you do with these patients is nearly always going to be a fusion of the subtalar joint and a decompression of the lateral wall. So the surgery we like to do now, we try and do percutaneously. Whereas, again, when I was training, these all used to get operated on after 2 weeks of elevation on the ward. Whereas now we want to get them to theatre day 1 or day 2 before they get particularly swollen. Because what we want to try and do is to elevate the bits of bone and squish them back into the right place, and then hold them with a few screws inserted percutaneously. The incision to open these up is pretty huge. It involves a big L-shaped cut down the outer part of the heel, and that has risk attached to it, because if that gets infected, you end up with an infected heel, and that's a bit of a disaster. For some reason, I managed to misspell medial. We very rarely have to approach the medial side of the calcaneum, but occasionally we do to reattach fragments. But the overwhelming majority of the surgery is done from the lateral side. So these are 2 of my patients coming up here. We've got this this first one, the plain X-ray. You can see here, this is the subtalar joint. This facet here should be articulating up here. So it has been pushed from there all the way down to there. It's almost gone through rotated through 90 degrees. We can see on the CT scan how it's been blown apart. That wall there should be sitting here. So it has been blown out to the side. This articular surface here should not be in 4 bits. This fragment here should have this medial wall smeared onto it. So you can see that's been driven up, this has been driven out, and this layer here has been smashed up. So this has been treated via an open approach. So we've elevated the joint, and I've used this rather cool-looking plate to hold the bone in the right position. And then they're allowed to walk on it after about 6 weeks or so. Overall, it takes a minimum of 1 year to 2 years to finish recovering from any of these significant foot and ankle injuries. So this is another one that I've done more recently. We managed to do percutaneously. So you can see how the subtalar joint's been driven down. It's been angulated away from the posterior facet, and it's the facets rotate. The body of the calc has been rotated away and causing this big gap. So we've reduced it because this fragment here has basically rotated down into the heel. And I put this pin in here, the back of the heel, and basically used a big lever. And it suddenly clicks. It goes clunk. You can feel it, and you can almost hear it sometimes. It goes. And then you can squeeze the bone from side to side to push everything back together again. And we have used a single screw from lateral to medial to try and stabilize this stretch of bone here. That's aiming for around about here on the scan. And then we've used these 3 screws inserted from posteriorly to hold this large fragment to this smaller fragment here. And these are the X-rays here and the axial view here to show the angle that they've gone in at. So they're the main hindfoot ones that I wanted to talk about. And then I'm moving on to some injuries to the foot to finish off with. This is the thing that is most commonly sent to my fracture clinic and patients come in saying, I've broken my navicular bone, and it's not a fracture. This is an accessory bone. It's a normal variant. So this is a bit of bone that's encased in the tibialis posterior tendon that runs down along here. and smears onto the navicular. They've always had it. It's always a bit knobbly, and there's a fibrous tissue that joins those two bits of bone together. And what happens is they turn their ankle over. So they do have an injury, and they rip the tissues that hold the two bits of bone together. It's called a synchondrosis. And that, because it's such a small gap, they carry on moving, it never heals, and they get chronic pain from it. So it's not a fracture because the bone has always been like that, but it's an accessory bone that is now mobile and painful. So if it stays painful, then we can do surgery to remove it. You diagnose it on a CT or an MRI scan. This is an MR scan. You can see that there's the change in signal here from the bone of the body of the navicular. There's the soft tissue element, and then there's the other fragments of bone. And we know it's not acutely injured because this, whilst it's a little bit white on the scan, is not really bright white, which is what you see with inflamed bone. So I've done an operation on him where I've shelled out that bit of bone. I've reattached the tibialis posterior tendon back to the navicular here. He also had a heel osteotomy because his heel alignment was wrong too. And then we also get these significant things that you see every now and again. We probably get a handful a year. It's another very significant dislocation. You don't need to be a rocket scientist to see that that's never looked right. So we have the talus head here that should be articulated with the navicular there. It doesn't look right on that X-ray. It certainly doesn't look right on that X-ray because they've also crushed down the lateral side here. They've crushed the navicular, the cuboid bone as it's come out. Because if you think that's moved over to the side, the talus has spun off the calcaneum, and the cuboid has all been crunched down. That was reduced in the emergency department just by picking the foot up, and it just slopped back in. So again, if you've got an abnormally shaped looking foot, it is perfectly reasonable to try and reduce it, because if you do it straight away, then that patient will have a much better course and recovery than if it's left out. We had one that was taken to, I think it was Good Hope Hospital, by a paramedic crew, and the paramedic who'd picked up the patient had realised that the foot was dislocated, had just basically grabbed the foot gently and straightened it out. And because it was so fresh, it just slipped back where it was supposed to be. And if that had been left until the paramedic had got him actually into the patient into the emergency department, 4, 6, 8 hours might have gone past. It would have been massively swollen and it would need to have been open to be put back. So as long as you are happy to do it, an attempt at reduction is perfectly reasonable. Don't force it. It should just slide back. So on this CT reconstruction, this is the cuboid bone. This bone, it should look nice and smooth like this bone, but it's all crunched up. And you can see on the image intensifier pictures, this is before I did anything to it. So you've got a small bone, and this is after I've jacked it out. So you can see it's increased its length. So we use a plate to hold the cuboid in the right shape, and then to stop it being squashed down again, and also to stabilize the foot here, we have to put what's called a bridge plate in to hold the plate out, hold the foot out to length, and that plate will need to come out again at some stage in the future. Otherwise, the foot stays very stiff. Liz Frank injuries, midfoot injuries, the arch of the midfoot. This chap, if it's, let me just get my X-ray up. Yeah. So this is a young girl who was she was 18. She was on her motorbike for the second time when she was going along and left her foot off the thing you rest your foot on a motorbike. You can tell I'm not a motorbike rider. When it hit a post that she was going past, and you can see on her plain X-rays she's broken her big toe. She's got lots of fractures, the metatarsal heads. She's got fractures and subluxations all across the whole of the midfoot here, as well as an injury to the cuboid bone as well. So she is basically tried to rip her foot off her hind foot as it hits the structure. This is the CT scan. You can see here the fragment of the cuboid that is sitting up at the base of the fourth and fifth, and the fractures of the big toe. Again, you could leave this and treat it non-operatively, but the patient will have midfoot pain and have problems. So we did an operation on her to reconstruct her foot and make it look more foot-shaped. So in the same way as we did on the other side with the cuboid reconstruction and a bridge plate to hold it out to length. So we've used that on the lateral side here. We straightened out the big toe and fixed the fracture there and used these plates to hold the metatarsals in the right place in the arch of the foot. These fractures of the metatarsal heads are allowed to heal on their own. It's unlikely they'll cause much problems. And they can usually be offloaded with an appropriate orthotic insole. And then we're coming on to the last few now. This is another motorcyclist. I've got a thing about motorcyclists. They keep falling off and hurting themselves. This foot is pretty mangled. The important thing about not being distracted here is that you can see all the problems with this foot here, but also note here, there's a medial malleolus fracture too. So he's actually got a broken ankle as well. And that would be easy to miss because all your focus is going to be on this midfoot here. So he's got a dislocation of his big toe. That needs to be reduced. He's dislocated most of his tarsometatarsal joints here. So that needs to be reduced. It's open. That needs to be debrided. This is his foot post-debridement with his external fixator on. So he's got a big splits down here. A lot of his fat pad is unstable. He's got this hole here from a open injury on this side here. This here is the road rash. So you've got a massive eschar from sliding on the road, and all that had to be debrided. So that's all been excised and skin grafted. And his injuries were so severe at the joints that trying to save the joints wasn't possible. So what I've done here is I've attempted to get those joints to fuse. So he'll end up with a very stiff foot here. And because that big hole here, the plastic surgeons have put a free flap on that they've harvested from his thigh. And it goes up from the tip of his big toe to about halfway up his shin. It's the longest free flap I think they've put on for certainly since the war. And it's all pretty huge. Now, this is all surviving because he's now 6 months down the line. Again, he's in my clinic on Friday too. So he's got a foot. He's got a big flap on here. It's going to be very stiff. We advised him to have an amputation because functionally he would be better with an amputation. But he didn't want to go down that route, so we went for limb salvage. And we just have to see how good his foot comes out because he's at high risk of infection. He's going to have a lot of stiffness. Those flaps are quite bulky and makes getting shoe wear on quite difficult. And then I'm finishing off with fifth metatarsal fractures. The take-home message on fifth metatarsal fractures is almost none need an operation. Hardly any need anything doing to them at all. Management should be early weight bearing as tolerated. There's no reason to restrict their weight bearing. You get people who get put into back slab plasters and are told they mustn't weight bear. There is absolutely no evidence that non-weight bearing makes them get better any faster. So we want them to get back to activity as tolerated. And then there is still a risk of non-union and the bone not healing. But we need to assess the whole foot because sometimes these non-unions are being driven by a foot deformity. So their heel might be malaligned or they might have another problem with the shape of their foot. So it's often not just a simple question of fixing the fracture or the non-union. You might have to do more advanced foot surgery as well. So keep the faith. If you see fifth metatarsal fractures, the overwhelming majority of them will heal. The ones that have a higher risk of not healing are these true Jones fractures. And this is a watershed area where the blood supply to that piece of bone is not particularly fantastic. So they do have a slightly higher risk of non-union. But even then, I would not look at primary fixation. I'll deal with them if they didn't heal afterwards. So here's some x-rays just to show. This is a shaft fracture, and you look at that, you think, how is that ever going to heal? How can that possibly be left without anything doing to it? The patients are sore, they're swollen, they don't really believe you that they're going to get better, but they do. I've never seen one of those not heal. I've only ever seen problems occur from attempting to fix them, but they all go on to unite. This is a tuberosity type fracture. It's not a Jones fracture because it's more proximal. I've had one of these. It really hurt. I did mine playing hockey. I had a few days off work and then went back to work because I was actually really comfortable in a walking boot. So I was on call the weekend. I went in, I put my leg in a plastic bag and carried on operating. I didn't drive with the boot on, but luckily I had an automatic and it wasn't it was on my left foot. So these types of fractures are really can be quite disabling with pain, but with appropriate rehabilitation, you can get over them quite quickly. This, however, is a Jones fracture. It's in the watershed area. As we said, they're at risk of non-union, but keeping them non-weight bearing or putting them in anything particular doesn't really reduce that risk. So I've given you a massive tap dance through the spectrum of injuries to the foot and ankle. I think the important things to be aware of is using a reproducible system of examination and history taking, and that will give you the most useful set of information, either to help guide your management or to hand over that patient. I think it's very important to start planning rehabilitation from the outset, and you plan your rehabilitation from the way you interact with patients, the way you talk to them, and where you are effectively honest with how long it's going to take for things to get better. And everything we do is trying to get these patients weight-bearing early. And what our goal of management is a stable, plantar-grade foot that allows pain-free ambulation. And that is it. Thank you.
Wonderful. Thank you so much, Alastair. And what, I know you said it was a, what do we call it, a snapshot tour or something like that, whatever the phrase is. But it really was probably the most thorough presentation we've had in a very long time, covering so many different facets and factors of ankle injuries. And I mean, I was saying to Alastair just before we actually started tonight that I'm notorious for suffering from a bad ankle. I fractured my ankle and sprained it all at the same time about a year ago, and I'm currently running around on a sprained ankle at the moment as well, which is what happens when you play grassroots football. So we've had loads of questions coming out as this has been going on, and normally I would ask the questions and sort of then ask you to give the answers, but because there's so many and just the time constraints, I don't suppose whether you'd be all right maybe picking your top 4 questions in this and asking them, and then the rest we'll answer by email, because I can download all the questions, guys, and we can get back to you on email with all the rest of the answers. So maybe if you want to choose your top 4 questions or top 5 questions, and we'll answer these ones live.
So Anonymous at 2029 said, which is quite a good one, in a pre-hospital care with a patient with an off-ended foot, if there's sustained loss of pedal pulse, would trying critical transfer be advised, or would assistance from advanced clinician, HEMS, etc., to reduce on the scene be the preferred treatment? A lot of it depends. That's a really, really good question, because it depends on where you are. And when you say time critical transfers, it might actually be quicker to get someone to the patient than it is to get to the trauma centre or trauma unit that you're aiming for. My preferred choice is don't stay and play, scoop and run. With that type of thing, if you're not in a position to reduce that limb yourself, you need to get them somewhere where it can be reduced. And if you are waiting 30 minutes for a advanced practitioner to arrive, then that is another 30 minutes of ischemia for that foot. So I think you have to give a real strong consideration for bailing out early and getting them to a centre as quickly as possible. But if you're only talking about waiting 1 or 2 minutes, then that's different. So a lot of it's the situation that you're in. But your first priority is getting that patient's ankle reduced. If you're comfortable doing it, then do it, because you could save their limb. If you're not comfortable or not supported to do it, then absolutely don't try. Get them to somewhere where it can be done. You know, for a CFR. What's a CFR?
Community first responder. So,
oh, right. Cool. So the waiting time. So this is the 2045 question. Should be a couple of hours before an ambulance arrives. Should attempted alignment be made without any pain relief? Yes, is my view. Is you have one go, and the earlier that it is done, the easier it can be. So you have one go at doing it. You're not there to make the patient cry and scream. And if it's that painful, then obviously don't do it. But you will often find that there is a window where actually reducing it is possible. The earlier or the quicker it is in relation to the injury, the easier it is to do. If it's a long period of time, then you're not going to be able to do it. A splint in the presented position be helpful? Yes, because if you're not able to reduce it, you don't want it waggling around like a windsock. So just get it blocked in a position where it's not waggling around. Is it okay to move someone either painful in the go in the position or okay, that is something that it's interesting, because you see on the television the reports of so-and-so waited for 12 hours in the garden with a tent erected over the top of them, and before the ambulance crew got there, and they're with their full family. And you think, why didn't they just move them and get them somewhere more comfortable? I said right at the beginning, don't be distracted. Always go CABC. Always think, is it safe to approach? Is there anything else going on? Could they have other injuries? If you are concerned and you have a fear is the wrong word, but you have a suspicion that they could obviously have a cervical spine injury, for example, then moving them is probably a bad idea. But it's about risk assessing what you're trying to do. So yes, move them if you can, if you're confident it's an isolated injury. Yes, I agree with that. And get them onto something so that they're not going to get hypothermic, because that's going to make things worse. But if you have concerns that they have something else going on, that they could have a spinal injury, for example, or a significant pelvic injury, then you should wait until somebody arrives. Boot with wedge, do I mean Darko chute? No, I mean an air cast boot with wedges, or I can't remember the name of the one that's actually better than that, that costs about twice the price. But basically, it's a boot with wedges rather than a Darko chute. That's for the Achilles tendon management. At what point would you refer to orthopaedics for ankle sprains? That's an interesting question, because acute sprains, there's no place in their management. One of the earlier questions that I skipped over, because I saw this one was on here as well, was about if you have lots of ankle sprains as a youngster, does that cause you problems in the future? It's about the quality of the rehabilitation. If you can be splinted, braced and rehabbed, then you should minimize your risk of problems. Seeing a foot and ankle surgeon with an ankle sprain is not likely to be particularly helpful for anybody. But if you have complications down the line in the rehabilitation, that's when it's important to. One of the reasons we do MRI scans of sprained ankles is not to look for ankle ligament injuries, it's to look for damage to the joint surface. So if you MRI scan a sprained ankle, it is not looking for a ligament injury. It's looking for chondral damage or damage to the joint. So that is why we do them. So if you have a suspicion with ankle sprains, I don't know what your job is, April, but the people who I get referred ankle sprains reasonably often through sports medicine and from the specialist physios who rehab the patients, the band 7 and band 8 physios who've got the acute ankle injuries from the emergency department. And nearly always it's because they're massively swollen, massively bruised, and they just don't look right. And if you've got a really bad sprain with a lot of swelling and a lot of bruising, that's not likely to just be a ligament. There's likely to be damage to the joint surface, and that should be looked at more closely. So if you remember the picture of the bruised ankle I showed, that looks like an ankle sprain bruising around the outside. But these patients with worse injuries, with normal looking x-rays, have ankles that are 2-3 times the size of normal. They look big, they're blistered, they're massively bruised. They just don't look right. And they're outside of your normal. So if you don't think it looks right, then get another opinion, is the honest answer.
And I can attest to that, because that's exactly what happened to me.
Yeah, there you go. And then Anonymous at 2050, I was taught the calc fractures should not go into plaster for about 72 hours with the swelling. My current orthopaedic put in the plaster and he did the day of injuries. I tell everyone to take calcaneal fractures out of plaster and not to put them in at all. You don't need to be in a plaster with a calcaneal fracture. What you actually need to be doing is having it elevated and looking at starting to rehab and mobilize the ankle. Putting them into a plaster doesn't help. You're absolutely right about the degree of swelling. They get massively swollen. So putting them into a tight back slab just increases their risk of having problems. But in general terms, they don't need to be in a plaster at all. A removable splint, it should be enough, basically. And then I'm just getting up. Oh, let's just scroll down. Anonymous, I know, where are you? Brian, you're asking about having plates and screws removed. In general terms, leave metalwork alone unless it's causing a problem. A little bit of aching and swelling during long walks, I would live with. In general terms, leaving the metalwork behind doesn't cause problems in itself unless it is too prominent. So I'd leave that alone. And then the fifth metatarsal fracture while on holiday. You wear a boot and inject. So you can use a boot. You don't need to. The boot is basically a painkiller that straps to the outside of the ankle and non-low molecular weight heparins to reduce the chance of a DVT. So that seems reasonable. It is a standard treatment, yes. In a pre-hospital emergency, if we come across wearing a boot, should we be mindful that if they're heparin? No, I wouldn't worry about it. I operate on people who are on low molecular weight heparins all the time. I can't tell the difference. So I really wouldn't worry about it. Treat the hemorrhaging. It's not going to be more difficult to control. Not everyone in a boot will be on low molecular weight heparins. I would suggest that they've been told to non-weight bear, because if you've been weight bearing in a boot, you don't need to be on the low molecular weight heparins. But I wouldn't worry about it. The ankle and the pelvic injuries, well, he's still in hospital. He will be in for a while longer. Pelvis has been fixed, or the femoral neck's been fixed, and the frame's on now. Taylor's split happened was because of the way he got tackled. So it's a shearing force where the foot has been fixed in the ground with his studs, and it's the leg and the ankle has been loaded in a funny way. So you never reducing the trapping nerves. Ian, I wouldn't worry about it. You're not going to trap a nerve or a blood vessel by reducing the dislocation. What will happen is that if anything is interposed in the joint won't reduce. But that hardly ever happens. I've only ever seen it once or twice where you've had to do an open reduction of an ankle. So you are not going to trap it. It will be in there. It will not reduce. And we're not telling you, and no time should you force a joint back in. Does the flap of skin and tissue stay there? Or is it removed with the wind? It stayed. Martin, I'm assuming you're talking about the guy with the open foot who had the really long free flap. That stays there forever. And it looks really quite weird, especially if they've had it taken from a thigh that's got a big tattoo on it. So you end up moving a lump of the tattoo down. And sometimes if you've taken a chunk of tissue out of our tattoo and you moved another tattoo in, it looks really weird. And the most common mechanism of injury for fifth metatarsal fractures is just turning your ankle over. I was playing hockey when I broke mine. I was running out of the penalty corner, turned my ankle over, and instead of spraining my ankle, I pulled off the attachment to the peroneus brevis tendon instead. So it's just turning your ankle over, basically. And I think I've actually managed to do most of them.
Too much all of them. Okay, wonderful. So, guys, obviously, you all know how it works now. If you aren't a member of Trauma Care, if you scan the QR code on your screen, which I'm sure many of you have done so far, you'll get your CPD certificate for just $1.99. All proceeds go back into Trauma Care and into the Trauma Care Research Fund as well. So that's it. It's a good way to get a cheap CPD certificate and get it into your portfolio for life. And with that, of course, as always, we do have to thank our sponsors for the evening. Galen with Penthrox. Some of you who are with us tonight, I think I recognise some name. David Nichols, saw you. April McKay, I think you were in the Penthrox one last week as well. And Sarah, who said hello today at the stand you were at Penthrox, and you said you might join us tonight. So hello if you are in there. But Galen with Penthrox, your first line emergency analgesic. It's about time. Penthrox are also at the Emergency Services Show if anyone is around. Simon's knocking about with his colleague on a wonderful stand right in the centre of the room, and you can find out all about Penthrox from them at the Emergency Services Show. If you're not at the Emergency Services Show, give the QR code on your screen a scan and you can get lots and lots of free CPD from them. That's all around the administration of this analgesic. And this is all their terms and conditions. And as always, I'm not going to read it out because I don't know half the words and will be here forever. And of course, as well, we're sponsored by Safeguard and more importantly, their subsidiary company, their sister company, Watergel Technologies. If you scan the QR code on your screen, you'll be taken through to see the lovely Andrew Ormerod, who gives a quick talk over the burn story and an application and usage of Watergel in a real life situation that they've asked us to share. And if you don't want to read the burn story, you could just go to www.watergel.com to read more all about this technology. And of course, as I said, Watergel are part of Safeguard Medical. Safeguard are at the ESS as well. I'm trying to think which ones I've bumped into today. So yes, the Grant's knocking around ESS as well at the moment. If you scan that QR code on your screen, you'll get taken through to their website. Or if you are in Birmingham, happen to be the NAC tomorrow, come and say hello down to them. They are right behind Penthrox. So I've gone to see these guys today as well. Icarus, the Power of Health, unfortunately couldn't make it this week, but they are hosting breakfast sessions at our conference. Again, guys, I would seriously recommend you get conference tickets, especially after, if you've been interested in tonight's talk with Alastair. We've got, I was at two talks that would probably two presentations that would really interest you. And I think they're both on the Thursday, actually, which is the Trauma in Sport talk, which is, it's got a whole section on different sort of limb trauma that you can get through injury through sport, which I'm definitely going to go and see because I'm an expert on that subject matter. And also the Rehabilitation talk, which I think might actually be on the Wednesday. And that's put together by the lovely Hannah Farrell. And that's looking at the national SCI. So that's looking at the spinal cord injury guidelines that have just come out recently. But Icarus are hosting breakfast sessions for us as well. So they're giving out free bacon rolls or vegetarian or halal options, all completely available, as well as free coffee, orange juice, everything else that you would expect at a breakfast. And from that, I think that that's all there is to say. So thank you very much, guys, for sticking with us for this CPD webinar. Alastair, thank you so much for giving such a thorough, wonderful, I've learned loads, and I always say to everyone, and you guys probably know as well, that I'm not medically inclined at all. But for me, ankle injuries is massively close to my heart and my foot. So I love learning about this kind of stuff. It's really, really interesting, and especially something that even I could use on the football pitch, actually, when someone, inevitably myself, goes down with a new injury. So Alastair, thank you so much. Guys, everybody stay safe, enjoy the rest of your week. As I said, if you are at the ESS, come and see us tomorrow. We're on stand S34. We're right behind Movember, which is really fun. They've got a really cool little roulette that you can go and play. Enjoy the rest of your week, enjoy the rest of your year if you don't come back. Thank you very much. Good night all. Good night.